Let's talk CPR, shall we? How should we perform CPR? And I don't mean which drugs we should give or how many defibrillators we should use to shock VFib. And Lord knows, I have talked enough on this podcast about how we should manage airways in cardiac arrest. Now, rest assured, I am going to spare you from another 5-hour podcast about PART and Airways 2 and Paramedic 2. Love me some Paramedic 2 and epinephrine. Likewise, I have said all I have to say about heads-up CPR. No, when I talk CPR here, I mean how should we approach the bread and butter of cardiac resuscitation? You know, the chest pumping, the lung fillingness of CPR. Now, there was an abstract presented at the NAMSP conference in January that, along with a couple of other papers, have made me question the fundamentals of how we do CPR, specifically around the harm of compression pauses. Stick around for a discussion about how our understanding, or at least my understanding of CPR, has been developing and how I think this new paper informs that understanding.
What is a lighthouse? It is a tower with a bright light at the top, located at an important or dangerous place. The main purpose of a lighthouse is to serve as a navigational aid and to warn of dangerous areas. Welcome to the EMS Lighthouse Project podcast, illuminating the darkness of current EMS clinical practice with the bright light of science. Here's your host, Dr. Jeff Jarvis.
Howdy, y'all. I'm Dr. Jeff Jarvis. Welcome back to another episode of the EMS Lighthouse Project podcast, where we shine the bright light of science on the darkness of EMS clinical practice. I want to start this episode by letting y'all know how we approached cardiac resuscitation at my agency in Fort Worth before the papers we're going to talk about, and I want to end with how we've changed that approach after these papers. Like many of y'all, we used continuous compressions in 2-minute cycles with asynchronous ventilations through some type of invasive airway during compressions, pausing only long enough to analyze and shock if needed or to change compressors. I'd like to go over the rationale for why we were doing this and then briefly cover the papers that started my questioning the wisdom of this continuous compression approach. Then I want to share the paper that just published, the one that grew from that abstract presented in January at the NAMSP conference. Now, in the late 90s, Dr. Uwe Kern and Berge, boy, that kind of sounds like a law firm. Do we sue them and how? Sorry, docs. This group of researchers published their work that they were doing down in Arizona on the impact of compression-only CPR. These were the researchers that taught us that bystanders rarely perform CPR, and it was because they thought mouth-to-mouth was kind of icky. And let's be honest, mouth-to-mouth is icky. That's just gross. No wonder they didn't want to do it. They also found that bystanders were more likely to do icky-less compression-only CPR. Their pretty reasonable assumption, backed up by their data, is that compression-only CPR, this is going to be a hard sell, compression-only CPR is better than no CPR. And then they did a series of pig studies. Now, one of these pig studies, I have to say, had a co-author named Dr. Joe Heidenreich. Now, the reason I bring this up is I did my emergency medicine residency with Dr. Heidenreich. So, Joe, if God only knows you're listening to this, howdy, man, I hope you're doing well. Now, that study showed hemodynamic benefit to compression-only CPR for the first 6 minutes of an arrest. And they even showed improved functional survival in these unfortunate piggies who got compression-only CPR. And in case you're wondering, yes, there actually is a swine cerebral performance category score. It adjusts for pigliness. They found that with pauses and compressions to give rescue breaths doing 15-2 CPR, the arterial blood pressure didn't recover to pre-pause levels for the first 2/3 of the following compression cycle. They interpreted this, correctly as it turns out, in support of compression-only bystander CPR. Now, they warned in the paper this applies to bystander CPR. They said this may not apply to professional CPR. And in a 2017 Cochrane Systematic Review and Meta-Analysis, Zahn and his colleagues confirmed better outcomes with compression-only CPR. For bystanders, they found no difference with EMS-delivered compression-only CPR. Next to the party was a paper by Dr. Ben Bobrow, who is then the chair of emergency medicine at the University of Arizona at Tucson, and his group introduced a clinical bundle of care to around 75% of the state of Arizona. They published the impact of this bundle in JAMA in 2008. The title of the paper was Minimally Interrupted Cardiac Resuscitation by Emergency Medical Services for Out-of-Hospital Cardiac Arrest. This was a large before and after study of a bundle that they called MICR, just like the title. It was also called cardiocerebral resuscitation. The protocol focused on early compression-only CPR by EMS for the first 6-ish minutes. It also called for 3 rounds of 200 compressions interrupted only for rhythm analysis and defibrillation as needed. This may sound familiar to some of y'all. Now, they also included initial airway management with only an OPA and a non-rebreather mask, so apneic oxygenation. They had no active ventilations for those first 3 cycles. Now, after that, they would intubate and ventilate asynchronously, meaning with compressions, for the remainder of the arrest. And other than encouraging early epinephrine, medication management was the usual and normal ACLS. Now, their results were very promising, and even more so when the protocol was complied with. Their survival tripled overall, and it increased by a factor of 8 among Utstein cases, meaning those with witnessed arrest and initial shockable rhythm. Now, that sounds truly amazing, and it was a good improvement effort. But then you got to look at where they started. Overall survival started at 1.8%, and Utstein's survival at 4.7%. Now, that improved to 5.4 and 17.6% respectively, but still not great. To put those numbers in perspective, current CARES survival, even after the COVID plunge, is 10.2% overall and 36% among Utstein cases. Now, I went back as far as I could in the CARES registry, which was 2013. Survival was pretty similar then, substantially better than even their improved efforts. So, to be overly critical here, I'd have to say in hindsight that tripling survival just ain't that hard when you're starting at 1.8%. Now, this study didn't look directly at continuous versus interrupted compressions, but it did lay the groundwork for such a study by the ROC group, the Resuscitations Outcomes Consortium. Now, Nichols and colleagues conducted a prospective randomized control trial at multiple EMS agencies across North America, comparing continuous compressions to 30-2. Now, shocking everyone, certainly me, they found no difference in survival. We were all expecting better survival with continuous compressions. Because after all, if it takes 2/3 of a compression cycle to get back to pre-pause pressures, we would expect better outcomes with fewer pauses, that is, continuous compressions. But that's not what they found. One big difference between the ROC study and the PIG study, showing that it takes 2/3 of the next compression cycle to get your pressures back, is that those were pigs. After all, no pigs are human, even if some humans are pigs. There's a difference, apples to oranges. Now, even though there was no statistical difference in this trial, there was a trend toward higher survival. 9.0 versus 9.7 with 30-2. Survival was slightly higher in almost all subgroups studied, including witnessed versus unwitnessed, shockable versus non-shockable, and those with versus those without bystander CPR. So let's just write that off for now as one of those things that make you go, maybe there's something there and it's just hidden by something, not sure what. Well, fast forward to 2021 to find out what that something was. There was a secondary analysis of this trial published that attempted to find really if there was something there. They looked at survival among those patients who actually got the type of CPR they were assigned to. It turns out that more patients assigned to continuous CPR actually got it than those assigned to 30-2. But among those who actually got 30-2, survival was higher than those who got continuous. Now, if that's confusing, let me just read the title to you because I really think it does an effective job of giving away the bottom line, and you could probably just read the title. CPR compression strategy 30-2 is difficult to adhere to, but has better survival than continuous compressions when done correctly. Now, this certainly casts some doubt on the benefits of continuous compression strategies. But the question remains, why? What's going on? What's up with that? It takes 2/3 of the next cycle to get your pressure back. Now, so far, we've talked about the attention in resuscitation research paid to compressions. What's the right rate, the depth, the recoil? What's the impact of pauses? And unfortunately, there has been limited attention paid to the other part of CPR, ventilations. Now, there has been, I will grant you, lots of attention paid to which piece of plastic those ventilations are delivered through. Obviously, I've covered most of those trials here. But there's not a whole lot just on the impact of ventilations. Now, 2 papers from 2023 start to change this. Dr. Idris and one of my colleagues and friends here in the DFW Metroplex, Dr. Betty Yang, looked at only patients getting 30-2 CPR, and they categorized each pause as having effective ventilations or not. Now, they used a rather generous definition of effective. They defined patients as having effective ventilations if at least one of the 2 ventilations during the pause delivered greater than 250 milliliters of tidal volume and a duration of more than 1 second. And you had to get that in more than 50% of pauses. So let's go over that definition again. For every pause, you were supposed to get 2 breaths as long as one of them met their definition, greater than 250 for more than 1 second, and more than 50% of pauses had at least one, that patient had effective ventilation. Now, how did they come up with this? They used some signal processing and monitor impedance channel data to determine volume and duration. Well, why'd they do that? Why didn't they just measure the tidal volume? Well, unfortunately, y'all know the answer to this. The vast majority of our monitors do not directly measure tidal volume. Shame, 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 shame. Now, fortunately, that is starting to change. Y'all know the Zoll X-Series Advanced. It has that tidal volume measuring capability. Really important. I'm really looking forward to what that capability allows us to do, both for clinical practice and for research. So signal processing, impedance channel, that's how they got the data. But why did they pick 250 milliliters? Well, this is important. That is roughly the volume needed to overcome anatomic and physiologic dead space, meaning you gotta ventilate more than 250 mils to actually do any meaningful gas exchange. Now, looking only at patients with BVM ventilation, they found that only 40% of patients had effective ventilation. In other words, 60% did not have effective ventilations. Functional survival among those 40% with effective ventilation, it was higher than those without. 10.6% overall survival with effective ventilation versus 2.4% without. That's a roughly 5-fold higher neurologically intact survival rate with effective ventilations. Kind of seems like an important signal here that ventilations matter. Now, the next paper was from Dr. Asgard and colleagues, again using some signal processing. This time they added in processing of the end-tidal CO2 waveform to impedance channels, and they wanted to determine the effectiveness of ventilation during compression. They found that frequent... Really, Cat? Come on. Nova. Okay, hold on. We got a cat break. Sorry about that. When a cat is knocking at the door, you had best open the door because ignoring them is not going to work. Back to CPR. What did they find when they were trying to determine whether you could effectively ventilate during compressions? Well, first they found 67% of patients were ventilated too rapidly. And we know from Dr. Ofterheide's work that hyperventilation is associated with lower survival. But the thing they were looking for, what is the effectiveness of ventilation with simultaneous compressions? Well, they found that in 80% of ventilations, pushing air in was opposed by pushing air out with compressions. Now, that opposing airflow was sufficient to negate any effective movement of gas. In other words, pressing in on the chest forced air out of the chest, and that opposed the movement of air into the lungs. That's bad. You're not exchanging any gas. You're not really doing anything except possibly decreasing preload. Not a good thing. Taken together, these two papers suggest that ventilations matter to outcomes and that effective ventilation is at best challenging when done during compressions, and most likely it's ineffective. So now we're at a bit of a cognitive impasse, a resuscitation conundrum, if you will. We need to pause compressions briefly to allow for effective ventilations, but even brief pauses, at least in pigs, causes prolonged drops in coronary perfusion. This brings us back to that abstract presented at NAMSP in January. It's now been published, and it was the missing link I needed to resolve this conundrum in my brain and to get me off my own little personal equipoise decisional high center. The paper is by Drs. Rose Yin and Lars Wick and their colleagues. The title is Recovery of Arterial Blood Pressure After Chest Compression Pauses in Patients with Out-of-Hospital Cardiac Arrest. It was published online last month in Resuscitation. Now, this study is a secondary analysis of data collected during the prospective Lucas active decompression trial. That trial randomized patients with non-traumatic out-of-hospital cardiac arrest in Oslo, Norway, and they randomized them to mechanical compression with either standard Lucas or the Lucas 2, the one that adds about 3 centimeters of active decompression. Now, in Oslo, they deploy physicians to cardiac arrest, and part of this study had the physicians place arterial lines and record continuous blood pressures in both of those study arms. The authors isolated monitor files of patients who had clean signal both before and after pauses, but without ROSC. They found 271 sections of compression cycles around pauses. So a cycle would be compression, pause, compression. 271 of those. The goal of this study was to evaluate the impact of pauses on arterial blood pressure. They measured blood pressure during several different compression cycle phases, during compression, during decompression, and then the average or mean pressure. They then compared these pressures before, during, and after compression pauses. The intent was to directly reevaluate that original Arizona pig study, but in humans. As a reminder, the Arizona study looked at 20 pigs, and they found it took up to 10 compressions, or 2/3 of the next compression cycle, to get blood pressure back up to the pre-pause levels. Now, as they are evaluating these 56 humans in cardiac arrest, exactly the population we're interested in, unless, of course, your agency is routinely resuscitating pigs. Not that I'm trying to judge your patient population, of course. All right, so maybe I've exhausted the pig jokes. I'm sorry, I just can't help myself. So in these humans, they found that compression and mean arterial pressure got back to more than 90% of pre-pause values within 2 compressions, roughly 1.5 seconds. They also found that pause durations, at least up to 35 seconds, did not impact that rapid pressure recovery after compression resumption. So what does this mean? Well, let me start with what I think it does not mean, because I can see easily how this study can be misinterpreted. It does not mean that pauses don't matter. After all, they found a clear drop in pressure during pauses. The mean arterial pressure dropped from 53 millimeters before the pause to 33 millimeters during the pause. That's bad. We don't like that. And obviously, the longer the pause, the more harmful it is. Poor perfusion is still bad. So to be crystal clear, we should continue to work hard to minimize pauses. Now, let me say that again, because, again, I worry about hearing, well, Dr. Jarvis said on his podcast, you don't have to worry about compressions or pauses. That's not what I'm saying. We must continue to keep all pauses to a minimum. That requires lots of training and practice on crew dynamics. We should continue to pre-charge our defibrillator or defibrillators during compressions, and then get back on the chest as quickly as we can post-defibrillation. This study helps us better understand the balance between risk and reward around taking short pauses, less than 5 seconds each, to provide 2 breaths, regardless of the type of plastic through which they're delivered. It appears that effective ventilation is important, but it's very difficult to provide during compressions. Now, this, along with a secondary analysis of that rock trial showing higher survival with well done 30-2, suggests that the risk of pauses is less than the potential benefits of effective ventilations. Certainly, it's less than we previously thought. I've been increasingly worried about the cost of ineffective ventilations. I don't think we're doing much when we provide asynchronous ventilation during continuous compressions. Now, when I talked about this with Dr. Modaya, who is involved in both of those ventilation papers, as well as with those rock studies, I mentioned that I thought the Lucas was an incredibly effective hemoptysis generator because of the amount of blood we were seeing during mechanical compression. He mentioned he had a similar experience, but he noticed a large decrease in that hemoptysis when he switched to interrupted compressions and ventilations. Maybe that hemoptysis is a function of the stress on the alveolar capillary junction, not from the Lucas, but from providing ventilations against the pressures, the competing pressures of compressions. So my takeaway from all of these studies is that we should be doing 30-2 CPR because the risks of short pauses are less than we thought, and the benefits of unopposed ventilations, meaning interposed with compressions, are more than we realized. This study reinforces this, and it was the tipping point for me. When I got back to Fort Worth from an MSP, I started work on revising our approach to pit crew CPR. We moved rapidly to inserting an air cue supraglottic and then establishing well-choreographed 30-2 CPR. We went back to dispatching an ambulance, a supervisor, and 2 engines to all cardiac arrest to assure we have sufficient manpower available. We delay applying the mechanical compression device for the first 15 minutes, and we dedicate one officer to directing the resuscitation and the other to acting as a family liaison, recognizing that just like with pregnant patients, we have multiple people to care for during an arrest. Now, as an aside, I saw Dr. Glockenflecken. I saw her speak about her experience when her husband, that's the social media guy, he's the comedian ophthalmologist with all the characters. Well, turns out he had an out-of-hospital cardiac arrest, and she gave a talk about the impact seeing that resuscitation had on her. If you haven't seen her talk, do yourself a favor and go find it. I know it's out there somewhere on the YouTubes. I think this paper on compressions, I think it's impactful, and I think it's a great example that papers don't have to be complicated, and they don't have to use confusing statistical models to make important points. This is a well-written paper, and I think it's straightforward. I urge y'all to give it a read. Now, as always, I love to hear from you. I love to hear your thoughts on this paper or any paper that we cover. For that matter, I just like hearing from you. Thanks for listening, and thanks for the care you provide our community every day. Take care, y'all.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the FlightBridge Ed podcast family and a Fire Dog production. Visit flightbridgeed.com for more information.